I think we are live, Shilpa madam.
Yeah, good evening, everyone. I welcome all of you to this 80th masterclass. I think this is a milestone for us that as we promised each other that we would be doing 100 classes, I think we have reached uh, almost like 80% of our goal in doing this masterclass. And adenomyosis has been a very, very popular topic. And as we have seen it in the yesterday's masterclass about adenomyosis in natural cycles, the induction protocols. So it's been viewed by almost 2,500 people, and we have got a lot of appreciation for that. All thanks to Dr. Jay and his ever practical points, which has been discussed in the class. And today's surgery, I think, is one of the masterpiece that everybody who are aspiring endoscopists should watch to improve their practical knowledge, and also practical tips that you get with one surgery is almost equivalent to reading like 2, 3 textbooks. So I urge everybody to watch it, though it is for 50 minutes. I think you all can spare that many minutes to watch one of a very, very good surgery, and the principles of it is. I don't think it's been mentioned in any of the books or literature that I have read. So, again, continuing with the series of adenomyosis, today's topic is stimulation protocols in IVF with adenomyosis. So, in this, again, he will be covering mostly about the practical aspects and tips, since he deals with huge volumes of laparoscopic surgeries in adenomyosis right from diagnosis, and also follows it up with the infertility treatment protocols, mostly IVF, since he is a referral unit for such tough cases. And I have seen him operate in Bangalore on adenomyosis cases, which has been a revelation for me and also gynecs who have attended the OT in Bangalore. So over to you, sir. I'll have a few questions after the explanation by you. You can start.
Yeah, yeah. Concluded. See, friends, in today's classes, we will cover stimulation protocols, and in tomorrow's class, we will try to cover the embryo transfer protocols with endometrial preparation. Okay, so I will just go ahead with sharing the screen. Shilpa madam, it's visible?
Your voice is breaking, I mean, can you check your internet, please?
Yeah, just a minute. Is my voice better now?
Yeah, better.
Okay, so I'll just start with the screen sharing. Can you see the screen?
Yes, yes.
Okay. So in today's class, no, we are going to be talking of stimulation protocols with IVF and adenomyosis. Okay. It's audible, Shilpa madam now?
Yes, yes, yes. Much better.
Okay, fine. So we again divided into three categories. One is diffuse, one is focal, and one is focal adenomyosis of outer myometrium. That is how you will divide adenomyosis always, no matter what stimulation you have to do. For focal adenomyosis of outer myometrium, as we showed you today in the live surgery, laparoscopic surgery is the first place, followed by which 1 month later you should be doing IVF stimulation. Okay, very, very simple, no change. Protocol in IVF stimulation should be antagonist protocol. Okay, and I will come in a little while to explain why there is no role of luprite depot. Okay, fine. Second, when you have focal adenomyosis, you will again divide it into two parts. One is focal adenomyosis less than 3 centimeters, another is more than 3 centimeters. Again, when you have a focal adenomyosis which is more than 3 centimeters, The treatment of choice is very simple. You will go ahead with laparoscopic surgery first. 1 month later, you will do the IVF stimulation with the antagonist protocol. With focal adenomyosis of less than 3 centimeters, one can try for something called as medical management. Medical management is always going to be letrozole 2.5 plus registerone 10 mg to be given for 100 days. Okay. And if there is a good volume reduction which occurs after that, okay, then you are going to be going ahead with IVF stimulation with an antagonist protocol. Diffuse adenomyosis rules are very, very simple. Is the size less than 10 centimeters or is it more than 10 centimeters? If it is more than 10 centimeters, then the treatment of choice is to do a laparoscopic surgery first. And then 1 month later, you should be doing IVF stimulation with antagonist protocol. All right. And if it is less than 10 centimeters, then again, you are supposed to do medical management like I have described here. Okay. And just follow this entire protocol. So if you understand this protocol, then we can move on to the stimulation aspects, because in stimulation of IVF and adenomyosis, we must always remember that when you are stimulating these two people, okay, here we will only be discussing of ovarian stimulation. Okay, we will not be discussing endometrial preparation. I will come to endometrial preparation in a little while. All right. So when you are doing ovarian stimulation, okay, just remember one thing. This guy is also going to be having associated endometriosis also in many, many occasions. Now, if there is associated endometriosis, then the protocol is always the same. Do not change your protocol. Okay. Just like how, even if there is diffuse adenomyosis, just to give you an example, if there is a diffuse adenomyosis of less than 10 centimeter, but the endometriotic cyst, okay, is more than 5 centimeter, then the answer is simple. You got to operate. Okay. So don't change the protocol. We have discussed this protocol in our previous master classes. Do not change the protocol. Okay. Then we start with this protocol of choice. So the protocol of choice for all the three categories, if it is diffuse, if it is focal, or if it is focal adenomyosis of outer myometrium, the protocol of choice is simple. You need to go ahead with a antagonist protocol only. Okay, the reason is when you give an antagonist protocol, all these patients are almost always going to have a free zone. Okay, so your long protocol or your GnRH agonist protocol will absolutely give you zero benefit in this case. In fact, it will cause ovarian suppression. Okay, and your ovarian stimulation will be prolonged and it will require a higher dose and more days if you are using an agonist protocol. So definitely we don't use the agonist protocol in this situation. Okay. Second is drug of choice. Remember, adenomyosis does not really affect anybody else in any other manner. So your drug of choice is always going to be HPHMG. There is no superiority of recombinant FSH in any situation. Okay, so don't worry about that. Dosage of choice. We have standardized the dosages. We have told it to you many, many, many times. And we have standardized it to 375. You can follow the same if you want to follow. Okay, protocol of choice, I just want to add one thing. Many of them might have associated low AMH. And if they have low associated AMH, then you can also consider the duo-stim protocol for these girls. All right, don't worry about that. Then comes the trigger. Trigger, very simple rule. If you don't understand anything, then you give 0.3 decapeptyl or 0.2 decapeptyl as your standard trigger. Only if antral follicle count is more than 10, you can give a dual trigger in this situation. So then the question will come, why not you should give HCG 10,000 as a standard trigger? The reason is You give decapeptyl as a trigger because majority of these guys are going to go for freeze-all. That is one thing. And second, a lot of these are going to be having low AMH. So when you give a zero point 0.3 decapeptyl trigger, it is going to help you in doing the second stimulation little faster for these patients. So just keep that in mind. Okay. Then just a minute, I will have to rub a few points here. What is going to be the media of choice when you do IVF for these people? Okay. So what is going to be media of choice? What is going to be the embryo of choice? Let me just clear off all this because I hope you all have noted down all these things. Remember one thing, guys, in adenomyosis also you should expect poor quality oocytes. Okay. Embryo of choice. As a result of which, your embryo of choice becomes the key player in determining your success rate. So your media of choice is usually going to be a single step media. This single step media will allow you an excellent day 5 culture because the embryo of choice is a day 5 culture, that is a blastocyst embryo. Now I know one thing for sure, there are many people, I'm going to cover this in the transfer protocol, who give depot of lupride to the patient and they ask the patient to take depot lupride 5 or 6 times. If the uterine size is less than more than 10 centimeters, they call it to be diffuse adenomyosis. And then what happens is the patient ends up spending approximately 6 to 8 months, and they promise the patient that you have 6 to 8 months of this and you will have a more than 50% outcome as long as you take donor gametes. Just remember, there is none of this is true. Okay. The reason why none of this is true is because the success rate in IVF is going to be determined by something called as the endomyometrial interface. And no matter what you do, if the endomyometrial junction, what we call, if that is altered, okay, if this thing is altered, then basically your success rate is going to be less than 15%, no matter what you do. And your abortion rate in these patients is going to be very high. As a result of which, choosing a great embryo, okay, is very important for your patients who are undergoing IVF with adenomyosis. And as a result of which, we give a lot of importance to time lapse imaging because it allows us to choose the best day 5 embryo when you are doing the IVF for these patients. When you are able to choose a great morphologically normal embryo and implant it in the patient, when I come and discuss the endometrial preparation for these patients, you will realize it really goes a long way in ensuring that these patients end up having a healthy pregnancy and these patients end up conceiving with a good success rate. Okay, I am not discussing endometrial preparations as a part of this lecture. This is only ovarian stimulation and the basics of stimulation. And we will be answering questions also only based on ovarian stimulation because tomorrow in the night we will be covering endometrial transfer protocols for adenomyosis.
Yeah. Shall I go? Shall I start?
Yes. Fire.
Yeah. So you did not add letrozole in your stimulation protocol.
No, it's mandatory. It's mandatory to add letrozole.
Okay. Yeah.
I did not mention it because we normally add letrozole everywhere.
Yeah. So that is another point everybody should
Yeah.
notice. Addition of letrozole is important. So so in a dual stim, okay. First you start on day 2, the first stimulation. You give 375 the HMG and 2.5 mg of letrozole, and then you give the decapeptide and you trigger. Then for the dual stim also you still add the subsequent stimulation. You add letrozole and the same dose of HPHMG.
Same. You need not really change the protocol at all for the second stimulation.
Okay. And so the poor quality oocytes. So do you think just adenomyosis itself is a reason for poor quality oocytes
No,
or?
adenomyosis, if you go through our endometriosis lecture, adenomyosis is associated with a lot of peritoneal endometriosis. Okay. And if the CA125 values, if you go through that lecture, it is a simple, even my nurse will answer. If CA125 values are more than 80, okay, then we don't want to do IVF first. We want to operate first and then we will do IVF. Understanding? Because that will reduce peritoneal endometriosis like how it happened in today's patient. If anybody of you goes through today's surgery, it is a lady who has been referred from Canada just for this. Somebody has seen our lecture, one of our past lectures on adenomyosis, some IVF consultant sitting in Canada, and she has asked the patient to travel to India to get this surgery done because they thought that they are missing out on this and they may not have the necessary laparoscopic expertise to clear it off, but it's the same protocol which they followed, and they've asked us that we are following your protocol. Okay, we just want you to treat it accordingly and send the patient back. So that's
Yeah.
okay.
But in today's case, there was peritoneal endometriosis on the right
Yeah.
side that we saw. Yeah, that was a good one. So tell me, I mean, do you think if the all the other factors like male factor is normal and tubes are patent, the AFC is decently okay, but there is adenomyosis. So when do you tell them that they need an IVF? I mean, is it just like a standard protocol, 3 cycles ovulation induction, then 3 cycles IUI, and then you tell them, yes, I mean, you need to go for
No,
IVF?
you go by the age and AMH criteria, no, madam. If the age of the lady is more than 35 and if AMH is less than 1.5, then basically IVF becomes your primary option. If the patient cannot afford that, then you ask them to try naturally for 3-4 cycles. Okay, and then do IVF. So it is completely the patient's call.
Okay, okay. So, again, I mean, this question I just started before we went live. So on laparoscopy, okay, what are the points that will tell you that this patient, though she has asked for a fertility sparing, but she has consented to do a more radical surgery in case if you find anything. So what are those points on laparoscopy that will tell you that this is not a case where fertility should be preserved? This is a case for hysterectomy. Uh,
Repeat surgery with uterus size more than 12 centimeters. One line answer.
That's the only criteria? I mean,
Yeah, because in that usually what will happen is, see, when somebody has operated it before, no matter what they say, the endometrial cavity is grossly distorted, madam. Okay, now on top of it, if I am supposed to do a flap reconstruction on a distorted cavity, that tubular cavity becomes a very hazy cavity. Okay, and usually after that, the chances of becoming pregnant is very, very less. Very, very, very less.
this is in a redo. But what about the
Yeah.
primary surgery when they come to you?
See, in primary surgery, the target is basically how bad the endometrial myometrial junction is. If the endometrial myometrial junction is good, no, madam, then we will really go all out in preserving that endometrium, because we know that once the uterine volume is reduced, the surgical outcomes are such so good that the patient will conceive. Right? Like if you saw in today's case, one tube was patent, right? But the other tube was so bad already that we couldn't have done much about it. Correct?
So, routinely, I know you do a hysteroscopy for all cases of adenomyosis. So, if you see a subendometrial adenomyotic spots on hysteroscopy where you just cut it with a cold scissor and you see that the brown fluid getting discharged from there, and if it is at multiple places. So, have you seen risk of intramyometrial pregnancies in such situations?
No, 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 no. I mean, the technique is you should not stop at that. You should put a laparoscope and you should take out the cystic adenomyosis. Because if there is a cystic adenomyosis, or let's say if there is an accumes, which is causing something like this to happen, okay, then you must excise that part. There is nothing which states that you should drain it. It is not an In fact, drainage is now gone, right? So you must excise it.
So you were talking about the stimulation and surgery in your classification that you wrote on your the flow chart. So do you suggest going for an OPO and then do the surgery and then do the FET, or you are that one person who says that just do the surgery, it will improve your oocyte quality. So I will do the pickup after the surgery. I mean, is it what is
Yeah.
the sense of events?
In focal adenomyosis of outer myometrium, please do the surgery first. The criteria which I have mentioned, madam, straightforward. Focal adenomyosis more than 3 centimeters, do the surgery first. And in diffuse adenomyosis more than 10 centimeters, please do the surgery first. Okay, I know everybody is, a great IVF specialist. I know that. But because you are so great, you will also be honest enough and accept it that the quality of oocytes which you get in these patients who have not been operated is suboptimal. Okay. And if you don't believe me, then you go and ask your embryologist.
So, what is the role of pre-treatment OC pills or pre-treatment GnRH agonist depot in such cases?
No role.
And what about pre-treatment antag on day 2, day 3 to
Can
synchronize?
give. No problem. Can be given.
And we see adenomyosis being associated with obesity in quite a few cases. So, do you see any change in the dosage or based on their BMI, or do you see any change in their response when you do the stimulation, or it is
No.
just?
No. Same.
And what are the difficulties in OPU that you see in these cases? I mean, forget about the ones that you have operated and brought the volume down. So, in case if the
You will have to go through the myometrium many, many times. Okay.
Mm.
And it is a tough myometrium. So when you go through the myometrium, no, and people are who are not very good and not very confident, what will happen is that needle will get skewed. Okay. Sometimes. Okay. So you will be somewhere and your nurse will be screaming, coming, coming, but nothing is coming. You know, not even drop is coming in such situations.
Okay. Does the location of adenomyosis matter? Like if it is diffuse on anterior wall, posterior wall, or in the fundal? So does the location of the thickness of the myometrium, does it really matter in the outcome?
No,
Yeah.
no.
Uh, as in like the tubal architecture, the tubo-uterine, the anatomy which is distorted, in which one do you think the distortion is maximum? Do you think it is at the fundus, tubal,
Posterofundal.
posterofundal?
Yeah.
And you think it is tough to operate on posterior fundal? See, today I saw you taking sutures very low down in the posterior wall of the uterus, which I don't think, I mean, a basic laparoscopic surgeon would be able to do that. So, which of these the walls are easier to suture, and I don't know. I mean,
See,
what?
the walls which are easier to suture are cases of diffuse adenomyosis. Because usually in diffuse adenomyosis, the serosal aspect is spared. Okay. The walls which are tough are the walls which have serosal infiltration. For example, focal adenomyosis or focal adenomyosis of outer myometrium. These guys will have infiltration somewhere along the serosa. So what will happen is you will end up losing the serosa. When you end up losing the serosa, and then if you have to achieve a tension free repair, that is a little challenging thing. Okay. In diffuse adenomyosis, that is the reason why you do a flap surgery in diffuse adenomyosis, because you already have flap. This flap you are supposed to superimpose on each other if required, okay, to form a thick posterior myometrium. Understanding? And you can only suture the flaps in diffuse adenomyosis. You can't suture flap in focal adenomyosis of outer myometrium.
Yeah, yeah. So when is it that you say that lap is not possible? I mean, forget about you, as in like when do you think like we should just open and do the adenomyotomy? I know many people don't do that. They would rather be trying with 3 or 4
See,
of IVF.
the rule of any endometriosis or endometriosis variant is simple. If you have done Fanon style, okay, and if you find that there is endometriosis or adenomyosis, okay, you should close the Fanon style, put a laparoscope and operate laparoscopically. Because the way in which the anatomical differentiation will come through the magnification of the laparoscope, especially when you are doing adenomyotomy, especially when you are entering those walls, okay, that is way better with laparoscopic surgery as compared to open surgery, because in open surgery we are not wearing loops, so we are already struggling with adhesions. Okay. And in that adhesions, if somebody asks you to cut the cavity properly and not cut the cavity properly, no, you will apply monopolar on his eye only. Okay. It is going to be something like that. So what will happen is in that situation, better to do lap.
Okay, so the bowel infiltration or bladder infiltration, which one is more
Common.
like detrimental? The adenomyosis. See, today we saw the bladder was infiltrated a little, and
Bladder and
then
bowel both were infiltrated today.
bowel was also infiltrated. So among these two, see, bowel, I mean, it will form a proper nodule and it will stimulate the uterine contractions, and it may compromise on the outcome
Same
of
is with
the.
bladder.
So it is
Same,
similar with
same.
the blood. Okay, yeah. Uh, Today we also saw that there was parametrial involvement in this girl. So how much importance do you give to this parametrial invasion?
Very important. If you don't release the parametrium, the uterus will not become mobile.
Yeah, I think that's very, very important where the dissection should be like, till the ureteric tunnel and the parametrial tissue where there is the fibrosis and nodularity. I think that should be excised to make the uterus mobile.
Correct.
So I think that is a good point. So during all this, see, I saw you coagulating a superficial uterine vein today. So all this, does it compromise the vascularity to the endometrium when you are planning for an
Vascularity in endometriosis and adenomyosis is already compromised. Once it is adenomyosis, that means the endometrial vascularity and the uterine vascularity is compromised. Only then it will be adenomyosis, madam.
no,
Otherwise, it can't be adenomyosis.
you're going ahead and compromising the already compromised vascularity, right?
No
See,
problem. Collaterals will develop. Ovarian is there, another side uterine is there. Everybody will help.
okay, yeah. And so the defect that we saw today, I'm sure,
Yeah.
like, I think you have closed it wonderfully well. So these are the patients who I think the myometrium may be weaker. And so do you advise them to go ahead with an elective cesarean later, like, or like what has been your experience? I know you do huge volumes of adenomyometry.
Definitely, we advise cesarean, madam. There is no doubt in that. And so far, we have had 5 patients total, out of which our second patient is getting operated on Friday now. Okay, where in pregnancy we have put a mesh on the uterus.
Oh, wow.
It
Okay.
is about to get ruptured, and we have put this double mesh onto the uterus. Okay,
Okay. Okay. So cesarean,
yeah,
any which ways you're doing for everybody in your center. So
yeah,
this, you do it a little early or like say 34, 35 weeks where you take
36 weeks, madam.
weeks. Okay. Okay. Yeah. Yeah, I think the rest of the questions is more related to embryo transfer that we will take it in
Tomorrow.
session. Yeah, yeah. Thank you. I think it was wonderful. It is a combination of endoscopy and fertility, especially adenomyosis and endometriosis classes. But I think it is worthwhile since he does both so well, and his experience is quite immense in dealing with difficult cases. As I have seen, we have easily operated more than like 35, 40 adenomyosis surgeries in Bangalore itself in the
Yeah,
past, 14 months. And the outcomes have been like superb. I mean, I can tell you like two patients of mine are, I mean, right now they are carrying their pregnancy in the first trimester. So doing a good surgery along with doing a good stimulation protocol, I think both go a long way in treating these conditions. So I thank everybody. Almost more than 100 people have joined us live. So thank you for your valuable